really lucky to have him here today, and I'll turn it over to Dr. Jones to further introduce and get going.
Great. Well, thank you guys very much. What an honor. I was just in Colorado last week. My son is in Golden at the School of Mines. I love skiing. My knees don't like black diamonds anymore, but we love it out there, and it's certainly beautiful. I was on the western slope quite a bit during my time, so I feel like I've gotten a much better flavor of the entirety of Colorado. So I'm really honored to be with you guys too, because you have such a powerhouse state of screening, not only with the Colorado Colon Cancer Screening Program and the leadership here with Elsie and Wesley, but also Andy Dwyer, and then a lot of my really great colleagues, including the late Dr. Dennis Anand at CU, was really an inspiration to me. And then I worked closely with one of your colleagues in the past, Dr. Jordan Carlitz at Grail. So I'm going to share my screen, and then I'm going to do a little more discussion about who I am and how I came to be on your screens today. So let's see what we're doing here. I'm going to share this one. And let me know if you guys can see that.
Looks good.
Yes.
What do you know? I did it. So today we're going to talk about sort of one of my favorite issues, which is not just the 45 to 49, but really, what I would consider a unification in messaging around colorectal cancer. Because we've really, in my opinion, focused so much on average risk individuals that we've forgotten about some of the other folks. And again, 20 years ago, that was probably the right thing to do right in the beginning parts. But now we have lots of other leading issues going on. We have a massive epidemic of early age onset colorectal cancer. We've got, new information knowing that people at younger ages are developing colorectal cancers that need to be addressed. We've got this incredible opportunity with genetics and genomics to identify cancer family histories, such as Lynch syndrome, which is the most common colorectal cancer gene around. And yet, because of the structure, if you will, of how we've approached messaging, I think it's had an adverse impact on the actual implementation of screening. And so today, what we're going to talk about is really, we'll focus on some 45, 49 challenges, which we have all across the nation. But we'll also talk about really a unification in colorectal cancer messaging. And I think one of the good things I would let you know is this isn't just coming out of Kentucky. This is now one of the top 3 priorities at the National Colorectal Cancer Roundtable, is to shift our messaging to an earlier, more methodical space rather than just waiting till someone gets there. So today we'll talk about lead time messaging and on-time, not only screening, but on-time diagnostics for people who are have sporadic under age 50 colon cancer, which is a big issue. So we'll be talking a little bit about high risk, average risk, as well as early possible diagnosis. And to me, no slide describes the paradox we're in better than this. And on the right, you see Mr. Stan Lee, and he's the creator of the entire Marvel comic series. And this is the classic person we've been chasing with colorectal cancer screening during my entire time in the space. But right up there with him on the podium is Chad Boseman, who really sadly died of colorectal cancer in his early 40s, that he'd fought for several years. And of course, he was one of the heroes in the Marvel series. And so I think really when I look at the past, we focused on Stan Lee, and I think in the future, we've got to expand that to include everybody at the podium and of all different shades and all different socioeconomic groups. And I love the work you guys are doing in community health centers and FQHCs. And at least in Kentucky, a couple of years ago, we did educational events at all 117 FQHCs in colorectal. So I applaud you for what you do. Here's my disclosures. I'm currently a senior medical director at Grail and Illumina. I was a consultant with Exact Sciences and Myriad, not currently, but over the past 2 years. And then I do have a consulting company. And so as you guys look into your clinic, and we're going to keep this a little clinical and not too researchy, is you've got a lot of challenges coming up because it's not just the 45 to 48s that have come into the screening age. You guys are also facing the catch up of COVID. And then on top of that, onboarding this new huge bunch of 40 to 45 to 49-year-olds And I think most importantly, leaving no one behind. And I think that speaks to making sure that we have equal access across populations. And so I'm just a gastroenterologist from Kentucky. I'm a country boy farmer. I've been working on colorectal cancer since 2003. So we had our 20th year anniversary. This is just me and some of my crew out at our farm doing a little cattle feeding. And, I always laughed when I first started because mad cow disease had only killed about 80 people in the whole world, but everybody knew what it was. But back in the early 2000s, hardly anybody knew what colorectal cancer was, yet it had killed millions worldwide. And so I always try to put that into perspective about how we can have an imbalance in the media based upon the problems that we're facing. And also in Kentucky, we've been very active in working on a variety of laws. And again, this is the colorectal cancer roundtable, and you all have an entity. A lot of states don't have an entity. So we, over the years, have passed a variety of laws, including insurance coverage mandates. We created a government-based committee where people who are stakeholders in colorectal meet in the Capitol on a regular basis with senators and representatives appointed to the steering committee, so that these important decisions aren't made on a quarterly or biennial cadence, but in fact on a monthly cadence. And so that's really been important. And then we worked extremely hard to get funding to make sure the uninsured were covered in Kentucky. And except for that 2016 where we got vetoed by one of our governors, we've had funding about $500,000 a year to make sure that not only people are aware, but they can get colorectal cancer screening. We have worked closely with Medicaid, and I hope that that's an ongoing issue in Colorado because Medicaid really makes such a huge difference to the people it serves. And so to have your managed Medicaid organizations part of your conversation and to be throwing in their weight and their capacity with marketing and reach in the market is really incredible. I know you guys have expanded Medicaid, which is great because that's the policy, the mother of all policy change. And we had that in 2014. But really in the last couple of years, since 2015, we've been focusing on a lot of these national issues. We closed the loophole for bait and switch screening for colonoscopies. So if you had a polyp, they couldn't switch it. And we also covered colonoscopy completions after a positive stool test. So a little bit ahead of the country, about 5 years or so, but still had issues and significant issues in terms of getting that across the finish line. We opened licensing of genetic counselors so we could get more folks in our workforce because we know genomics and germline testing are going to be part of the future. And then finally, we passed the Awareness and Access to Genetic Testing Act in 2019, which essentially stated that if you meet NCCN guidelines for genetic testing, that it should be covered for as a no out-of-pocket cost service. And then this last year, about 2 years ago, we put into play the nation's first pharmacy-based colorectal cancer screening protocols, where pharmacies who've undergone appropriate training can actually screen people with stool-based methods and then or refer them for colonoscopy if they meet guidelines, as well as identify people with symptoms. It's an entire post. That's a whole nother lecture I'd love to talk to you guys about, but we have to go where people are in terms of their screening. We can't expect, and probably some of the greatest lessons learned is we can decentralize medicine and really switch out of our bricks and mortar history. So 45 by the numbers. When you look at it, it really makes great sense. I'd refer you to the American Cancer Society article, why they pushed on this, and this came out several years ago. They were well ahead of the USPSTF. But essentially, people 45 to 49 have the exact same colorectal cancer statistics as people 50 to 55 did a decade or two ago. So it only made sense that if it worked for those folks, it'll work for these 45. And so what it does is it adds 19 million people to the current 87 million people eligible. So that's like 3.5 Colorados or 1 New York state. And because some of these folks have already been screened, I think around 10% of the folks have been screened, it adds about a small percentage of this, 90%, to this 27 million who are unscreened up to 47 million. So not quite a doubling, but darn near. And so I think the real key here is that we've got a lot of more people to screen, and it fits into that initial paradigm was which is, for me, this is part of a large population. And there's still some headwinds with these folks, right? I mean, as I always say, it's still colon cancer and it's poop, so we're never going to get over that. We've had some major issues, and these next three, I think, are really related to what COVID did to medicine. And again, you guys have been on the front lines. It's really changed access. In a way, I think the healthcare system, which was having trouble already, got further broken by what I just call the COVID tax, right? Where everything had a lot more tax. The cost of medicine went up, labor went up, the cost of goods went up, everything went up as a rise in inflation related to the changes. And again, I think there's been a significant increase in the loss of trust, as well as, not necessarily interest in medicine, but people are spending their time on the line, on computers, and again, these folks in their 40s, a lot of men don't even have primary care doctors. Women have had primary cares or work around their gynecologic healthcare and pap smears and birth control issues for some time. Men have none of this. And then we've got to really understand we're probably capped around 80%. When I look at screening, about 80% is about as high as any state's gotten. And with breast cancer having a over 50-year run at this, they're still capped out in the mid 70s. So we're probably capped. But I do think it's important to know, I think you've got a lot of tailwinds in your community. First of all, the incredible prior work that's been done over the last 20 years. And I'm going to add to that even current advertising by companies that make colorectal cancer screening modalities. Colon cancer has never been more known and more aware than it is right now. And again, I stand on the shoulders of the people who brought all this, and I think we all do. Number two, I think these folks are more tech reachable. They're on their phones. We don't have to use traditional media. We don't even necessarily over time have to use traditional bricks and mortars, as long as we can continue to connect with them and go where they are. Also, we have lots of screening options now. And again, that's going to expand dramatically with blood-based options coming out. And so again, the ability to do telemedicine, to reach out, to mail things to people, to use third parties to help deliver screenings, I think is really going to be critical. And no matter if we want to admit it or not, blood-based screenings are going to be real because nobody wants to mess with their poop and nobody wants to get a colonoscopy for the most part. So don't be shocked when this comes on, and be mindful as you look at it, how much you want to resist versus how much you want to, endorse and integrate. I do want to let you know that not so much for the 40 to 49s, but the 50s and over, there are definitely major technological thresholds that are going to be crossed around blood-based multi-cancer early detection. I would argue for the groups that we take care of, those with highest cancer incidence rates, that we really need to rethink how we do this. And again, think about all the work we do on lung cancer screening for smoking with low-dose CTs and how hard that's been. Well, the number of smoking-related cancers, if you include head and neck, esophageal, stomach, pancreatic cancer, ovarian cancer, colorectal, they actually dwarf lung cancer. So we've got to be able to broaden our view. And I think this new technology in multi-cancer is going to do that. So be aware of it, read about it, understand it. Not quite ready to be into your guys' space. We have several years, but definitely understand it. But I think our two biggest tailwinds are down here at the bottom: data management. Now, we have been entering data into computers for years and years and years, and it's about time we put data and computers to work for healthcare. And that not only means being able to query your database to find out who's in that 45 to 49 range, who's up to date with screening, but also hopefully understand their risk. And again, this is where it's going to expand beyond 45. 45 and 50 previously are where we start average risk for normal risk screenings. It's not where colorectal cancer is moving. Colorectal cancer is moving younger and younger, and it's moving outside of our traditional population. So as we develop messaging strategies and strategies within our offices, we have to really recognize this. And this is where I think unification comes in. And finally, we are in the artificial intelligence era now. And so finding ways where AI can do more than a funny poem on chatbot GPT is really essential for us to identifying folks. And this is really just a vision of where we want to go. Right now in the green is what we do. We hardly identify anybody who's at risk early. We miss the vast majority of people who should be screened at 40. And then so we begin to start screening those high risks, probably at 45 maybe, and then those average risks at 50, at 45, maybe 40% of those folks are getting screened on time. And again, I think that the reality of this is this all stems from our communication strategy. And so our goal in looking forward as we move from 50 to 45, as well as really unifying the communication strategy, is we want to begin to identify those people who are at high risk and screen them at the appropriate time, which means shifting this whole curve to the left. We absolutely want to find the people who at age 45 who are normal risk be screened on time, not 40%, but rather, push up towards that 80% goal we talked about. And again, we want to have compliance. We want to have screening happen year after year and time after time, particularly with blood-based and stool-based testing. It's really critical, not that they be screened one time, but they undergo a testing schedule. And so what we've done really at Kentucky, and what is going to help us with our 45 range, is we want to work this problem backwards. So every one of you guys got on this meeting at 2 o'clock Eastern time, 12 o'clock Mountain time, not because we called you at 2 o'clock Eastern and 12 o'clock Mountain, but because we contacted you, months in advance, and we let you know what was going to happen. And we probably got 2 or 3 or 4 different emails. So I think you got to start by deciding, when do you want the behavior to occur, in this case, screening. Then secondly, you want to figure out where they get their messages. Like I said, men generally don't have any doctors. So if you're trying to get messages to them through their doctors only, you're going to miss men. Women, I think you'll get not so much of an issue there. But again, don't just think we're messaging at people. We need to be focusing our messages at providers, at their health networks, at your community health centers and FQHCs. The insurers have a role to play. And then not only do we use media, but we've got to get away from traditional media and start using digital and small screen. Again, men have low health numbers. Now, don't laugh at that men joke. I've got someone off mute there. So that's pretty funny, but I'm one of them, so I can't help it. The other thing is, how many times do you have to message someone to get a screening done? Messaging, takes multiple times. Very seldom do people get a test done. And realistically, how often can we get the message delivered to a person? Prevention is the best message. You can prevent colon cancer or not, you can find it. And if we can identify high-risk people and get them to comply and get screened on time, that'll give more message attempts to the patients who are at average risk and increase screening there as well. And again, what we all believe in is more shared decision-making in average risk folks as we have more choices. So, but here's what we don't have to do. I love this. We don't have to develop new guidelines. We don't have to redefine what elevated risk is. We have to worry about states anymore. We used to worry about which state you were in. We don't have to worry if guidelines work. They do work. We don't have to invent cancer family history. It already exists and hopefully is implemented in every one of your FQHCs. We don't have to figure out if marketing works. We just got to figure out how to make marketing work for us and colorectal cancer. And then finally, we don't have to develop new options. Corporate America is going to take care of that. It's really up to us to understand where they fit and how they fit. And so this is really how it all started with 45. And again, what you're going to see here are various age ranges at the top: 20 to 29, 30 to 49, 40 to 49, and 50 to 54. You can see that every one of these curves is going up in the 20s after the year 2000. Whereas everybody over 55, their rates of colorectal cancer incidence are going down. And that's because of screening and the impact of removing polyps, as well as identifying cancers at the earliest stages. And so what we found, and this really came out about really a decade ago, and I want to congratulate Colorado. You guys were way on the tip of this. Fight CRC as well out in front. We thought we were doing great, but the fact was colorectal cancer was changing. And in fact, the cancer was going up in these incidences. And so this is really the first hint that not only was the disease changing, but telling people at age 50 to get screened at age 50 wasn't going to work. Just doesn't work. I mean, I'm in the restaurant business as part of my external life. We never advertise to come to Easter brunch at 2:00 on Easter. It's too late. They've missed it. And when you message people at the time you want the screening done, you've also missed it as well. Likewise, we've got this huge issue with early age onset colorectal cancer. It's almost 20% of colorectal cancers are under 50 now. Many of those are related to family history. About 60% of those, about 40% of those, either from genetic syndromes or familial issues around polyps and colorectal cancer. About 60% of them have no family history whatsoever, and they tend to present with symptoms. But the problem is these folks tend to have delayed diagnosis by months, and I'm talking sometimes 3 to 12 months, as you can see, because they don't know about the symptoms, they're not aware, and so it takes them a long time to make an appointment, and then many doctors aren't aware of this significant trend, and they have a delay in diagnosis before they get in to see their primary care provider and eventually get diagnosed. And so one of the issues around a more unified messaging strategy that takes care of lead time is to begin to educate people about the symptoms of colon cancer, as well as help to try to identify those people who are at high risk and should be screened earlier. And so again, the more important thing is we can bring many of these messages together. And for those people who develop colorectal cancer symptoms under 50, and again, many of these are going to be in that 45 to 49 range, get those folks in the office quicker and to a diagnostic resolution more quickly. So let's talk about under age 50 colon cancer. And again, understand that that's the reason 45 to 49 came in here. And you can see the map of 20 to 49 here, as well as 50 plus. And there's a lot of overlap. And again, unfortunately, I live in one of the worst states in the nation, although we've improved our screening rates to 75% now, with almost 1,000 people each year not getting or dying from it related to reductions in mortality and incidence. But again, not an insignificant issue. And some folks that you wouldn't think would be on that list are in fact, on that list. And here's Colorado living the good life out in the West with extremely high health metrics throughout, but you have your populations where colorectal cancer remains an issue. But I broke this down a little further. And what I did was I looked at the colorectal cancer state. Let me see, you can see this transcript. Okay. And so what I did was I took the rank of colon cancer burden, which is essentially if you combine their rank of incidence and mortality, and I compared those to their rank for early age onset colon cancer, with the idea that if you have a lot of risk factors for early age onset colon cancer, those risk factors probably drive your overall cancer burden. And in fact, this is what came out. 8 of the top 10 states who have a high burden of colorectal cancer rank in the top 10 states for under age 50 colorectal cancer. And of the next 10 states, and I got Georgia circled because that's where the CDC lives. And I was just in Georgia last week, a couple of weeks ago, giving a talk. 7 out of the 10 top burden states in colon cancer of the second 20 are also driven by under age 50 colon cancer. And so to me, not only did we move this down for statistical reasons, but this whole focus on beginning to recognize the impact of under age 50 colon cancer to our overall colorectal cancer burden is really dramatic. And so essentially, we've basically been acting too late, informing too late, waiting until people present with symptoms rather than trying to identify them as risk factors. And again, I think when you do cancer family history, you don't just do colorectal, it's all cancers we need to be worrying about in terms of how that fits in. And so to me, this is extremely strong evidence that in order to change your colorectal cancer space, oops, sorry about that. Let's see what's happening here. In order to really reduce your overall colorectal cancer mortality, that's going to be driven and it's going to be run by your under age 50 space. And so I think these are inexorably linked, and so did the American Cancer Society and the USPSTF, which is why we're focusing on educating people and getting them screened. And what I would say is if you take one thing home in terms of lead time today, before we jump into it, It's that 45 should be the finish line for communication on colorectal cancer screening, not the starting point. Now let's talk about how we can unify our messages. So first, a little bit about marketing essentials, right? We have worked really hard, and I know the Colorado group has done a great job. South Carolina and Kentucky are probably three of the most aggressive states that have worked on this. And we've worked endlessly on the message. But unfortunately, there's more to marketing and communication than just the message itself, like a real catchy piece like treatable, preventable, treatable, beatable. That's a great message. The two issues that we've talked about, and not nearly enough, and I think that are going to shape our next work at the Colorectal Cancer Roundtable, and hopefully Colorado, certainly they are in Kentucky, are the timing of the messaging, meaning how far in advance of when you want something done do you need to start talking to that person? Because essentially we know that the rule of sevens in marketing is you've got to hear a message 7 times before you're going to change your behavior. So how many times are you going to need to get a message to a person, and how long does that take time-wise? Is it 5 years in advance, 6 years in advance? If you have a great message, maybe it's only 1 year in advance. But let's face it, we're not as great as McDonald's in terms of things that people want. This is a somewhat pushed away piece by folks. So I would expect we need more frequency of messaging with a longer runway of timing in order to reach that. The other thing I want you to really take home here is that patients are not the only targets. In fact, you guys are targets. That's why I'm here discussing this with you. You guys are in primary care. The roundtable has been a target, and now they're adopting. Fight colorectal cancer's at the head of every list, and I never have to target those guys. I'm actually going to school on what they're doing. But also insurers ought to be part of this, because again, it makes sense for them to save lives. So again, everything we're going to be talking about today is not, we'll talk about the message a little bit, but mainly we're going to focus on timing and frequency, and maybe a little bit about how your message changes since you're talking to people in their 20s and 30s and 40s. And so this is an illustration out of the paper we published in 2020 in Cancer, and it's called On-Time Screening and On-Time Lead Time Messaging and On-Time Screening, that we published with Dr. Anand and Dr. Shroy. And this really isn't my baked one, but I just wanted to show this because what it suggested is we really need to start talking to people in their mid-30s about their risk stratification, family history. Do you have polyps and cancer in your family? If so, we need to make sure that they're getting screened on time, which is at least age 40 or potentially earlier, a decade earlier than their first degree relative. So again, knowing that we need multiple times to message them to achieve a behavioral response, starting early in the 35s, and that's what we agreed to. That was a negotiation. And then obviously continuing messaging till we get to those folks who are 35, 40, or 45. It had not changed in every state when this paper came out. And so again, I would refer you to that paper for further reading. But really, this is what we want to talk about. And again, how to reach those people that we're working the hardest to reach. Because what we have now is what I call the current message package is you hit 45 and we tell you to get screened. We know what's going to happen. People are going to wait years and years and years to get screened. The men, particularly who are not in your office, but may in fact be on your rolls, we're going to have to reach out to them electronically because they're not in our offices at the same degree that females are. But as we look around about trying to get people screened on time, we know we have to push this message back several years and not only include screening in our messaging, but really the other important parts of being a doctor and a clinician, and particularly around colorectal cancer. So first of all, lifestyle modifications. And again, as we see, those are really best communicated when you're young, not when you're 45 or 50, although it's always a great time to quit smoking, eat better, lose weight, all which can reduce your risks. Secondly, where do we start bringing that family history of cancer in? Again, screening a person who is high risk at 45 isn't the same type of protection for that patient at age 40. And now those ages are closer than ever. But again, developing that family history as part of our colon cancer messaging. identifying and evaluating symptoms is really critical. But if you just start at age 40 or even 35, we're still leaving a lot of people out in the cold in terms of early age onset sporadic colorectal cancer. And so really what this looks like when you bring it together is a lot like what we see in breast cancer, where people are really educated about breast cancer and breast health much earlier in their life. And again, I don't think you elevate colon cancer above everything else. I'm a pan-cancer, advocate. I think cancer family history is really important for many issues: breast, cervical, ovarian, as well as colorectal. And again, it really consists of three things that I think can be blended in quite well. Lifestyle modification really makes a difference when you're younger. Family history and test. And again, don't ever think that the first time you take a family history, you're going to get a complete family history. It takes time to develop, and family histories develop. But knowing what people are at risk for has been around longer than CAT scans and blood tests. So we've got to reintegrate a good cancer family history as well as other family histories issues into our matrix of work. And the sooner the better, I think. And then finally, letting people know and understand the symptoms of colorectal cancer when it presents sporadically, knowing that they need to get to those doctors immediately. There is no such thing as rectal bleeding that's okay, regardless of your age. And I think in this new timeline, rectal bleeding is colorectal cancer until proven otherwise. It should not be the other way around, where we attribute it to hemorrhoids or IBS and some toxic combination of not having a complete diagnostic profile. And so what we've really done is we've worked really hard in America on this 50 and now 45, which is why we're here. But again, this is part of it. You cannot start messaging here and get these folks. Likewise, about 20% of people are high risk and need to be screened at 40. And because their risk of colon cancer is 2 or 3 or even 4 times more elevated, turns out that many of the people who are developing colon cancer come from this 20%. So if you're not identifying them and screening them early enough, we're just sort of saying high risk doesn't matter. We'll just lump you in with the rest of the folks. But in fact, again, we want to blend this thing. And this is where we spent most of our time, money, and resources. But for the early messaging package to really have an impact, we're going to have to actually invest in it and change some of our systems. And again, I don't know if we start at 18 or 21. I just know we need to start younger, in the 20s, in order to help these folks with sporadic and under age 50 colorectal cancer, better manage their risks in their lives. So in Kentucky, we've been really doing this for almost a decade now. We've focused on early age onset for quite a year. So here's some of the messaging. And I do think one of the issues is when you're messaging younger people, particularly when you go down there, you want to message to where it brings folks like that in. Again, all of our messaging used to be Stan Lee. Now we're going to broaden that out. So these are a couple of examples, and I just wanted to show you a couple. Over here on the left side of the screen, this is our Appalachian version, our rural version of Prevent Colon Cancer Throughout Your Life. And it essentially takes themes like mountains. This would work great for Colorado. We actually have one for African Americans, we have one for Hispanic, and we have one for urban culture. So we're more than welcome to share that all with you. And you guys can totally put your own logo up in here and really personalize it. But again, it's sort of in a funny avatar kind of cartoon way, walks you through this: exercise, diet, don't smoke, eat smart, know your family history, be aware of the symptoms. And again, by 35, be talking to your doctor, or in your case, talking to your patient about when you need to be screened and what the options are. Obviously, colonoscopy for high risk. And again, appropriately patient screening as the finish line and communication here at 45, not the starting point. Because of that, also, we tend to try to get a little crazy in our talk. So because I live in Kentucky, we had to do basketball. We just got a great public service announcement from Daryl Griffith, who is a famous basketball player who has colorectal cancer in his family. This is one of ours talking about early age onset sporadic. If you're having symptoms, don't sit on it, all the way with the toes curled and everything. We're a big agriculture issue. Our biggest issue with colon cancer is in Appalachia. We have equivalent rates of screenings and outcomes in African Americans and non-African Americans in Kentucky. but our big disparity is in Appalachia. So we thought we'd bring this in. In fact, our number one ad that we tested digitally was people on a four-wheeler driving through some muddy stuff. So we tested all of these. We actually did about 3 million of these in 2 Appalachian regions. And also we did this in an urban setting as well. And what we could identify is we could, in fact, have greater open rates and click-through rates than the standard healthcare assay. So if you have good messages and catchy pieces, you can use this. We geofence things like schools, shopping areas. Our target was, in fact, 30 to 45. We didn't target people above that in terms of our geofencing. And essentially, this was a great issue to know that if you're trying to reach these folks, you can use small media. You can use what's on their phone, because this is, in fact, where people live. And this is where healthcare is going to eventually, move to, whether we like it or not. And again, the screening recommendations haven't changed except for this average risk at 45. So family history remains unchanged, inherited cancers remained unchanged, and then chronic medical conditions. So again, the 40 to 45 is really a great opportunity, I think, to use some of these tools. And we'll talk a little bit about data crunching and how you can mine your data. Because again, if those quality metrics and everything we've been putting in there can help us to identify and communicate with the folks with this age change, shame on the computers. So let's talk a little bit about what the future sort of is going to look like a little bit, because I think it's critical that you guys anticipate and become part of the change. And again, this is George Patton, and I love this cartoon here. And he was the first person that came up with tanks, he and Eisenhower, and this whole new way of warfare. And we are fighting a war on cancer, right? I didn't come up with the analogy to war. And if we are fighting a war, we need to get with it. And I love this cartoon that said, tell this guy over here we don't have any time for his newfangled gadgets. We've got a war to fight. And so I would just let you know we're going to be accelerating in tools. Colonoscopy will remain the screening of choice for people at elevated risk or diagnostically. But for people who are average risk and asymptomatic, be ready for a rainbow, if you will, of screening options. So, and the reason I think this is important is because, medicine has changed a lot. We had the physiologic age, microbiology, CAT scans and endoscopies were digitally. And now we're clearly in the molecular and genomic era of medicine. And AI and computing should be taking a lot of this work off our shoulders. Find me every patient in my FQHC who's 45 and above who hasn't been screened for colon cancer. Right, and get them something. If you can pull out better information about family history for colorectal cancer, their symptoms, that's a chance to shift this discussion and argument earlier. But again, I would expect each of you guys to be able to query your database, find out who those folks are. And again, maybe your approach is, we can't do shared decision-making because we're so behind because of COVID. So we're going to get everyone a stool test. We're going to order everyone a multi-target stool DNA test. Later down the road, blood testing. One of the great things that colonoscopy does, of course, is it identifies polyps and removes them, that then prevents colorectal cancer. Stool tests and blood tests do it to a lesser degree. But again, the most important thing is what test gets done will help your patients. But again, make no doubt that you guys we are living in this world now where AI, computers, and molecular and genomic places are going to accelerate. And thank goodness they are. We need better testing for folks. It just has to become accessible. It has to be affordable, and it can't be out of the reach. And we've got to make sure it impacts everyone across the spectrum, not just becomes a tool to widen gaps in care. And so again, just be aware that you're going to have expanded stool DNA options. Don't think Cologuards and Exact Sciences are going to have the only patent that does this type of a piece. I think we'll have multiple blood-based options coming around. Multicancer is coming. They tend to have extremely high sensitivity in colorectal cancer. That's why I think they'll be really important. And likewise, again, a whole nother lecture, really something to be aware of and understand where it fits. And and people would like feedback as well from you guys. And also one-time genome sequencing when you're 18 years old or even when you're born, that will look for these hereditary cancers and identify people who are at risk. And again, it won't just be for colon, it's going to be for the entire cancer risk profile. And so again, that cradle to grave piece, I think, is really going to happen, and it's going to influence the entire pathway, not just screening, but also prevention, as well as how we manage cancer across. So just beware, be reading, and I want you to be curious and skeptical. Do not think that this is going to be one size fits all or be a perfect match. Other paradigms we can look for: people with colorectal cancer. Eventually, you're not going to wonder if you do genetic testing. Every single person's going to get a somatic panel to figure out if it was genomic or germline or not. And then they'll be testing that tumor to figure out whether or not they're going to benefit from alternative types of treatment. We're finishing a 5-year chart review of microsatellite instability staining from pathology specimens, and we've gone from about 50% to over 70% compliance. But again, that's still leaving 25% of people out who may not be getting proper treatment because of not using these molecular-based tools. And so when you guys look at it, and we're going to roll up here, these are questions for your clinics, your FQHCs. How do we improve our screening rates? I'm hoping you're already asking that, and that's why you're on the call today. How can we elevate the family cancer history collection and review? Do we benchmark it? Do we reward it? Because if you want to improve something, you need to measure it. And again, I think it ought to be part of every history, and it needs to be repeated on a regular basis because it changes. Number 3, how do you build and deliver an early messaging platform given colorectal cancer's changing face and the need for lead time messaging? And then finally, put your data to work, put your IT guys to work. Collectively, you guys could potentially hire someone to give you a broad view that could be spread out across the entire FQHC landscape. So here's the now, and this is where I would recommend from my standpoint. You got current challenges. Number 1, you got to catch up, and we got low knowledge around early age colorectal cancer in our population. So data mining, bulk ordering FIT and Cologuard. One of our hospitals sent 24,000 stool-based tests out to their patients and followed them up to get ahead of COVID and to catch up. Again, hopefully we'll be out of that space. That includes your not up to date, your 45 to 49s, figure out how to interact with people across the spectrum, and then learn to embed early and lead time messaging for colorectal cancer into your overall process, because that's how we're going to get the biggest bang for the bucks and most people screened on time. 19 million folks to onboard. Again, that's all about data mining, again, with those same folks and embedding that messaging platform across. Bulk ordering is a great way to catch up. And we're actually working on a pharmacy protocol here to get those people who are not engaged with the healthcare system. In rural Kentucky, people go to the pharmacy 10 times a year more often than they see their physician. So more messaging, more opportunities for screening. And finally, leave no group behind. I mean, we haven't talked a ton about disparate populations, but given that you guys are in the CHC world, las personas se hablan español, African Americans, new immigrants, people in rural issues, people who aren't connected, they will benefit the most from earlier and low frequency messaging. This has to happen in FQHCs and CHCs because of the populations that we care for in those settings. And don't be afraid to have different messages for people who are a little bit different in terms of their identifiable factors, being urban, rural, African American, or Hispanic. And finally, my last slide here is really how I see the world. And I'm not a Dungeons and Dragon guy. I'm just a 62-year-old gastroenterologist. But knowing what we know about colon cancer, it is extremely non-pragmatic to start the fight when the opponents are at the gate of your castle. That is not how we do things in our life. That's not how we set this conference up. It's not how we do anything that's of critical importance to us, where we actually engage the longer term planning and information process. So Way out here in front is all about awareness, lifestyle, primary prevention symptoms. It's okay to have some tacos, but the obesity epidemic we're facing is going to increase cancer dramatically. And we've got to start our fight out here if we're going to have an easier battle in the future. On-time screening for these high-risk folks, adenomas, genetics, out through this entire portion, we need to let people know about the symptoms again. Because this, messaging and finding these high-risk folks gives more messages to that average risk person who's not as concerned, making them more likely to say yes when they finally get to age 45. And so I'm going to stop my screen share there. I'd love to take some questions from all you guys. I've sent copies of the deck to Wesley, so she has this if you're interested in any of the processes. So with that, I'll throw it back to our lead team in Colorado.
Thank you so much. We did have a question in the chat that says, are insurance companies covering colorectal cancer screening at age 45, including Medicare and Medicaid?
Well, I would say until 2 months ago, the answer was yes. But about within the last month, there's a court case going on. First of all, prior to this court case, the answer was yes, because it's a USPSTF grade A or B recommendation. Insurance companies are mandated to cover colorectal cancer screening starting at age 45. There's a court case going on that doesn't just address colorectal, but all cancer screenings and whether or not they are mandated to be covered. Stay tuned. I don't think that any of the insurance companies are going to change their policies until this court case is settled. I suspect it will be dismissed.
All right, so if anyone has any questions for Dr. Jones, feel free to come off of mute or put it in the chat. We have about 10 minutes for Q&A.
Yeah, come on, this is your time. Otherwise, I'll search you down in your community health centers next time out in Colorado in 2 weeks. What I'd like to know from some of the community health centers, how do they see their greatest challenge to shifting to 50 from 45? I'd like to really learn from the folks on your all's team who are in our audience. Or maybe Wesley, you have some insight that you could share, because it is a challenge to make such a big shift. All right. Well, sounds like you guys are going to be in good shape because you're 40 to 45, 45 to 49s are getting knocked out. I think it's a challenge, actually. I think the health systems in Kentucky are sort of going along our guidelines. They're working on using their database and then doing bulk mailings. Whether or not they do a bulk mailing of FIT or something else, I think is a question. I would certainly educate people in advance and then bring the testing in at 1 or 2 levels past the messaging. But again, maybe starting that mailing in their early 40s to prepare them. And I've got something from Victoria. She goes, I think younger people are taking better care of themselves and may want to do the screenings. I hope so. I think they have more information now than ever. But at the same time, obesity is increasing more than ever as well, which is going to be a major risk factor for colorectal cancer, as well as general health problems. So I think people are more informed, but I'm not convinced that they're acting on it more. Again, you guys are uniquely positioned in Colorado with a very young, healthy, and affluent population. Probably not the case in a lot of the community health centers or for Native Americans. So let me just look over here at some of the chats. Have the hospital system hand out Cologuard kits? No, you can do bulk mailing, and the hospitals with St. Elizabeth's Hospital in northern Kentucky, they have a health system. And if you want to reach out to me, I can try to connect you with their folks. We actually had a couple of presentations on this at the Southeastern Colorectal Cancer Symposium a couple of years ago, and they'll be happy to walk through what they did and again, how they did it. So somebody likes proactive. I get it. We struggle with access. Yeah, I think access is broken. A lot of health systems have had an extra layer of complexity with COVID testing, or just, again, access. A lot of physicians retired, et cetera. So I think that's why you have to really consider, and this is what I suspect the future will look like. I think most asymptomatic average risk folks will be directed towards a first order screening test rather than having colonoscopy be their first test. Because I think colonoscopy will be oftentimes in the future reserved for people with symptoms who are already at elevated risk because they've had polyps or colon cancer, who have family histories. I still think it's a wonderful screening test for people who are of average risk, and that's the one I choose. But I've got many patients who've chosen this other one. And one way around the bottleneck of colonoscopy is to use a first-line screening test, such as a stool-based test, and in the future, blood-based test. Great question, though. And again, I assume, Lynn, that you're talking to the folks that you referred to and letting them know you're having this issue. And Colorado's Medicaid expanded, so most of your folks have insurance, I would expect. Not all, but most. But I think that's a place where you reach out and talk to the folks who you're sending your business to, and let them know what's going on and ask them how they can help reduce that wait time or that access time. Yeah, I know, but they don't have increased capacity. I realize it. That's why I think that using more non-colonoscopy based screening tests really takes the population down from a large number to a smaller number that have positive first order stool-based tests that are more likely to have colorectal cancer. That's one way to help them with their backlogs. And I think that's a great place to have a dialogue with them. All right, Shanna Koster, how does someone who's under 45? Well, I think the first thing is that if you're under 45 and you've got a family history of colon cancer and polyps, you go to your doctor and you say, hey, I read the guidelines. I meet screening guidelines for age 40 or 35 or some number. Let's talk about how we get this done. Because again, insurance companies cover screening for high-risk individuals. And so I think it's really a two-edged sword. Hopefully we're educating the people to know, hey, I'm at risk, I want to get screened earlier. But the major educators are really still the healthcare systems, insurance companies, as well as places where healthcare is delivered, like FQHCs and CHCs. And so again, to me, that's part of that early messaging, lifelong educational pathway that we need to be giving to people. And again, I hate to be so siloed on colon cancer, because I really think obesity is broader, smoking is broader, family history is broader, but really a more integrated approach of talking about that cancer family history and bringing it to bear in terms of on-time screening for high-risk folks. So that's a great challenge. And again, I suspect that with the NCCRT unifying this messaging to start earlier and at a more of a lead time, I think we'll get a lot of great solutions from across the country where people are going to give us their ideas and their insights that we'll be sharing to help do that. But likewise, we'll be looking to Colorado as a leader here to bring some of your learnings to the rest of the country through the teams that you have.
And building off of all of this work around lead time messaging, and I got a couple direct messages that people really loved the examples that you shared for what messages resonated with people in Kentucky. So could you share a little bit more about that process to develop those messages and test them with younger populations to see what might resonate best with people's communities?
That's a great question. Yeah, so we did focus groups, of which I was not even a part of. I wasn't allowed to get in there and bias them. So we did focus groups with about 10 people from Appalachia who were in our demographic between 30 and 45. And then we also did studies in African-American populations in Metro Louisville. And then we developed images. We came back to the focus group and basically went through what they felt were their top 10 images. I do want to thank Fight CRC, who through grant money helped us really perform this. We were doing 2 or 3 things at a time, pharmacies as well as digital messaging, but we did do focus groups and we tried to identify those messages that resonated with folks. And again, that rural message looks primarily Anglo, and it is because it's 99% Anglo in our Appalachian region of Kentucky. But through the Colon Cancer Prevention Project, we are more than welcome to share all these images and all this work with anybody through you guys that you can then disseminate out in the fields to at least do some brainstorming, as well as consider what messages might be appropriate for rural folks, Hispanic folks, or African-American folks in the Colorado region.
That would be great. Yeah, so we'll be sending out an email with the copy of the slides and the recording. And if you're willing to share some of those links to those materials, that would be really helpful as well. And we'll also send out
copy Amanda.
Yes,
She's my boss.
Also send out Dr. Jones's contact information so you can follow up with him for any questions, or reach out to Wesley or I, and we can help connect you as well.
Great. Well, I want to thank you guys for the opportunity to spend this hour with you today. It's really exciting. And again, I just want to reemphasize, Colorado is so lucky to have its team at the fore really leading this. And again, great work, and thanks to Fight CRC for all their general support. And I hate to say it, if we can do it in Kentucky, you can do it in Colorado.
Thank you. All right, everyone. Hope you all have a good day. Like Elsa said, we'll send out a follow-up email. Thank you again to Dr. Jones. And yeah, look for that. Thank you.
Bye, guys. Have a great day.
Have a good one.